I work in the autoimmune disease unit of Cruces University Hospital in Vizcaya, Spain, and I'm going to talk to you about a challenging clinical case of a patient with a diagnosis of systemic lupus erythematosus. I declare no conflicts of interest, and you can take as many pictures as you want during this presentation. I present a 52-year-old woman that was admitted in the emergency room with fever, cough, and bloody sputum and bilateral lung infiltrates. She had been diagnosed of systemic lupus erythematosus 7 years ago, and she had been diagnosed of lupus nephritis 1 month ago. Thus, she was being treated with hydroxychloroquine daily, prednisone 10 mg per day, being the maximum dose administered 20 mg per day 1 month ago, cyclophosphamide 500 mg fortnightly, having received 2 pulses before the admission, angiotensin receptor blockers, and calcium plus vitamin D. The day of the admission, she referred class 3 dyspnea developed in the last 24 hours, cough with hematic sputum, and fever with no shaking chills. The physical exam revealed normal blood pressure, a little high heart rate, high fever, and low oxygen saturation being 91%. She was in a bad general condition, and the pulmonary auscultation revealed inspiratory crackles on both pulmonary bases, and she also had bilateral leg swelling. With all this information, complementary tests were performed. First of all, the blood test revealed hypoxemia, low hemoglobin levels with 7.6 grams per deciliter of hemoglobin, being the previous one 2 weeks ago 9 grams per deciliter. She had high ferritin levels, normal leukocytes, a little low complement levels, especially C4, and stable renal function with 1.2 milligrams per deciliter of creatinine, being the previous one 2 weeks ago 1.08 milligrams per deciliter, with low albumin levels. Then the chest radiography was this one. As you can see, there are bilateral lung infiltrates. In this situation, the patient was transferred to the intensive care unit, considering the risk of needing mechanical ventilation in the future, and a CT scan was performed. As you can see, the bilateral lung infiltrates were confirmed. So with all this information, it is easy to think about a diffuse alveolar hemorrhage due to the low hemoglobin levels and lung infiltrates in a patient with the previous diagnosis of SLE. But there is one clinical sign that can be a little confusing: the high fever, because it can let us think about infectious bilateral pneumonia in a patient that is under immunosuppressive treatment. So before I go on with this interesting case, I would like to ask you, what would you have done in this situation? You would have performed a bronchoalveolar lavage and wait for the results, maybe treat the patient with empiric antibiotics, administer 1 milligram per kilogram day of glucocorticoids or other immunosuppressive agent, maybe do both, or any other option. So before I go on, I would like to highlight some information regarding diffuse alveolar hemorrhage in SLE that can be interesting for this particular case. First of all, high fever can be a symptom of a case of diffuse alveolar hemorrhage in SLE without infection. And it is also important to remind that patients that develop diffuse alveolar hemorrhage have normally a history of previous organ involvement, especially kidney, and because of this they are normally treated with previous immunosuppressive therapy, just like our patient. It is also important to highlight the high mortality of diffuse alveolar hemorrhage in systemic lupus erythematosus that can be as high as 50% of the patient, and traditional risk factors of this high mortality are patients that need mechanical ventilation and a concomitant infection during the process of the diffuse alveolar hemorrhage. So what we did was we treat the patient with broad spectrum antibiotics, meropenem and linezolid. We administered 3 pulses of 250 milligrams of methylprednisolone. We administered 1 gram of rituximab, the second dose 2 weeks later. And we continue therapy with 10 milligrams per day of prednisone without increasing prednisone dose after the 3 pulses of methylprednisolone. And the results of the complementary tests were this. The bronchoalveolar lavage revealed diffuse bleeding with negative cultures, but 2 days after the admission in the intensive care unit, the blood cultures were positive for Streptococcus pneumoniae. So the antibiotic therapy was desescalated to ceftriaxone and an echocardiogram was performed with no signs of endocarditis. As you can see, this is the comparison between the CT scans. The one above is the day of the admission, where the pulmonary infiltrates were clear, and 10 days after the admission there is no pulmonary infiltrate, and there is a little pleural effusion that was easily treated with diuretic therapy. What happened during the follow-up? The patient experienced complete recovery and complete renal remission, with no modification of our prednisone tapering scheme for severe lupus flare, which is 30 milligrams per day during 1 week, 20 milligrams per day during the next week, 15 milligrams per day during the next 2 weeks, 10 milligrams per day during the next month, 7.5 milligrams per day during the next month, and then 5 milligrams per day during the next month, trying to taper it to 2.5 milligrams per day when possible. That's all. Thank you very much for listening.